I'm honored today to introduce Dr. David Lamb for his grand rounds on euglycemic diabetic ketoacidosis in the modern era. Dr. Lamb received his medical degree from the University of Maryland and completed his internal medicine residency at Thomas Jefferson before moving on to complete his endocrinology fellowship here at Mount Sinai. As medical director of the Mount Sinai Clinical Diabetes Institute, he champions diabetes-related initiatives and care pathways across the Mount Sinai health system, ensuring and promoting quality health and care for those living with diabetes. As director of the hospital-based diabetes clinic, Dr. Lamb has led multiple initiatives specifically for the inpatient management of diabetes. Dr. Lamb's research interests include diabetes technology for both type 1 and type 2 diabetes, as well as outcomes for hospitalized diabetes patients. Please join me in giving a warm welcome for Dr. David Lamb.
Great. Thank you for such a nice introduction, and thank you all for spending your Tuesday morning with me, and for the warm invitation to give you guys grand rounds. In terms of disclosures, I do have or have had investigator support from the following companies, some of which whose medications will be discussed during this presentation. There will also be a discussion of unlabeled or unapproved investigational medications, those of which are listed here. In the context that this is a discussion of off-label use in type 1 diabetes, as it's been reported in the medical literature. This is specifically not necessarily a recommendation for their use, though. So to start with a case. This is a 29-year-old female with a history of type 1 diabetes and asthma who presents to the emergency department with nausea and vomiting, which started the morning of presentation. She reports elevated blood glucoses over the last 24 hours despite administering correction doses of insulin through her insulin pump. Suspecting that her insulin pump was not functioning properly, she administered a correction dose of subcutaneous insulin via a syringe, which, based on her blood sugar, which did improve her glucose control. However, the next morning, she still continued to feel poorly and actually started to experience nausea and vomiting, which prompted her to present to the emergency department. She denies any sick contacts, fevers, polydipsia, or polyuria. Her diabetes history is significant for being diagnosed at age 6, and she has no known microvascular complications. Her past medical history consists of type 1 diabetes, asthma, and anxiety. Her social history: she does not smoke. She's a social alcohol drinker with 1 glass of wine the evening prior to admission. No recreational or illicit drugs, and she's actually a graduate student visiting New York City, and her endocrinologist is out of state. Medications: she takes insulin lispro via a continuous subcutaneous insulin infusion pump, otherwise known as an insulin pump, canagliflozin, 100 milligrams once daily, and alprazolam. On exam, her heart rate is elevated at 120, blood pressure is 114/54, her BMI is 24, and her exam is notable really just for dry mucous membranes. Lung and abdominal exam are unremarkable. Lab data on admission to the ER is significant for a bicarbonate of 12.2, a glucose of 191, and a calculated anion gap of 25. Her venous blood gas has a pH of 7.21, and her urine demonstrates ketones greater than 160. The inpatient diabetes service is consulted due to the presence of ketonuria, but in the absence of hyperglycemia. And ultimately, she is diagnosed with euglycemic diabetic ketoacidosis in the setting of a likely insulin pump malfunction combined with concurrent use of an Sglt2 inhibitor, canagliflozin. So this case really inspired me and has raised a lot of discussion amongst our colleagues within our division to raise the awareness of this entity called euglycemic diabetic ketoacidosis, for which I'll refer to just simply as euglycemic DKA. The objectives for this talk are to first identify risk factors that are associated with the development of euglycemic DKA in patients with type 1 diabetes, and then to discuss the diagnosis and understand the general management principles of euglycemic DKA. So the traditional definition of regular plain old diabetic ketoacidosis is important to first understand. So it's one of our few diabetes emergencies, and most medical students probably can tell you the exact diagnostic criteria for DKA. But this consists of a blood glucose greater than 250, a metabolic acidosis with an anion gap, and ketosis. However, in euglycemic DKA, There's still the presence of metabolic acidosis and ketosis, but with normal blood glucoses. Now, this presents a very diagnostic dilemma. You ask any patient with type 1 diabetes, or really any clinician, what is the hallmark of diabetic ketoacidosis, and they'll tell you it's hyperglycemia. Our patients with type 1 diabetes know that if their blood glucoses are elevated, that's when they have to think about DKA. Euglycemic DKA, therefore, presents a significant dilemma. Now, this is not necessarily a new diagnosis or a new phenomenon. In 1973, it was first reported by Monroe and colleagues in a case series of about 211 cases describing the metabolic derangements in diabetes, 37 of which had what they considered to be euglycemic DKA. And I quote, "This paper considers the other extreme of the broad spectrum of diabetic metabolic decompensation, namely severe ketoacidosis with a plasma bicarbonate of 10 or less without pronounced hyperglycemia, the blood glucose being less than 300. We have called this syndrome euglycemic diabetic ketoacidosis, for lack of a better term." So how do we think this happens? There were two proposed mechanisms based on the majority of patients that were presenting in this case series. With type 1 diabetes, many of the patients were reported to have been starving or significantly restricting their carbohydrate intake. So what starts with starvation leads to a reduction in caloric intake, specifically carbohydrates, and a concurrent reduction in insulin dosing. This results in a relative insulin deficient state and then shifts the metabolism to become dependent more on lipolysis and an increase in free fatty acids, leading to ultimately an increase in keto acids. Concurrent is an increase in counter-regulatory hormones with an increase in urinary glucose loss, and this, combined with glycogen depletion in the setting of starvation, leads to euglycemia. The combination of euglycemia and metabolic ketoacidosis leads to euglycemic DKA. Another significant cohort in these 37 patients were pregnant patients who actually had poor control of their diabetes and in response were reducing their carbohydrate intake. So in pregnancy, due to increases in placental lactogen and cortisol, this contributes to insulin resistance. With the reduction in the starvation that happens when women are trying to control their blood glucoses a bit better, there's a relative insulin deficiency, and then the same pathways of increased lipolysis, an increase in free fatty acids, an increase in keto acids. In addition, in pregnancy, there's an altered renal glucose threshold such that there's an increased clearance of glucose from the kidneys, leading to glucosuria. Again, the combination of glucosuria and an increase in ketosis leads to euglycemic DKA. Now, this was not a very commonly reported diagnosis. A quick PubMed search looking at the number of times euglycemic DKA was mentioned in published literature reveals that it was a relatively unreported diagnosis up until about 2015. In order to understand both why our patient had euglycemic DKA and why until 2015 this was an underreported diagnosis, I think I'd like to first take a step back and talk about just the general state of type 1 diabetes care, its limitations and its challenges, and then talk about why patients with type 1 diabetes may be seeking off-label treatments, such as our patient, in pursuit of a better glycemic control. Finally, I'm going to circle back to euglycemic DKA and talk about mechanisms of more modern post-2015 DKA, and then also to close with the principles of management in euglycemic DKA. So what is the state of diabetes care? There are two classes of medications that are approved for type 1 diabetes, insulin and pramlintide. This pales in comparison to the 12 classes that are approved for type 2 diabetes. There are a host of FDA-approved devices for insulin delivery and glucose monitoring. This includes the bare standard of insulin pens, vials, and syringes, glucose meters, but more recent advances have included continuous glucose monitors, which consist of a subcutaneous sensor which detects interstitial glucose and translates this to predict near real-time blood glucoses. Insulin pumps, such as what our patient was using, are basically devices seen here in this picture that deliver rapid-acting insulin. They contain pre-programmed rates, which specify the hourly rate of insulin infusion, and they also provide the patient guidance with how much insulin to take based on carbohydrate intake and also their blood glucose levels. More advanced therapies include the combination of using insulin pumps with glucose sensors, including the threshold suspend systems, which basically will halt insulin delivery if a low glucose is detected on the sensor. Predictive low glucose suspend, which actively predict if a patient is about to experience hypoglycemia, and therefore, in response to that, reduce insulin delivery. And lastly, what's considered to probably be the most advanced therapy currently is a hybrid closed-loop automated insulin delivery, otherwise known as the artificial pancreas, which can both increase and decrease insulin delivery based on sensor blood glucoses. So with all of this technology and a whole whopping 2 classes of medications available for treatment, why would any patient with type 1 diabetes use an off-label, non-FDA approved medication? Well, the Dcct and Edik trials really demonstrated the benefits of intensive glucose control. And these were landmark trials in which patients with type 1 diabetes were studied over 6.5 years and looked at the intensive control versus conventional therapy. And what they showed in the 6.5 years with the Dcct and the 17-year follow-up with the Edik trial was that there was a significant reduction in microvascular complications as well as a reduction in cardiovascular risk. But achieving blood glucose control to the level of which the Dcct has really set the bar is difficult. The majority of patients with type 1 diabetes are not meeting this goal. So this graph here is data from the T1D Exchange, which is a conglomeration of diabetes clinics, one of which Mount Sinai is a part of, and consists of about 26,000 patients living with type 1 diabetes. And in this graphic, it shows the mean hemoglobin A1C reported across the spectrum of ages. And you'll note here that no matter what age, most people are reporting an A1C greater than 7%. So the vast majority of people really aren't meeting their goal. And this is for a number of reasons. First of all, insulin therapy causes hypoglycemia. In this same 26,000 patient cohort, nearly a quarter of the patients reported severe hypoglycemia. So this is hypoglycemia that results in seizure or coma since their diagnosis. Not only is there a limitation in hypoglycemia with insulin therapy, there's also weight gain associated with insulin therapy. In the Dcct trial, the intensive arm patients gained nearly 5 kilograms in the 3-year period. And in another cohort, the Pittsburgh EDC cohort with type 1 diabetes, they also report an increasing prevalence of overweight and obese in type 1 diabetes between 1986 and 2007. This here shows in the gray and the black the prevalence for BMIs greater than 25 and greater than 30. So suffice it to say, type 1 diabetes care isn't exactly where we want it to be, and it's also fraught with challenges, namely weight gain and hypoglycemia. And therefore, patients with type 1 diabetes are seeking off-label therapies to avoid the negative effects of approved treatments, all in the pursuit of achieving better glycemic control. So what's out there? What are the medications that people are using? I'm going to start with talking about 3 major classes that have been reported in the literature for off-label use in type 1 diabetes. The first class is Metformin. It's a biguanide which reduces hepatic gluconeogenesis and promotes peripheral glucose uptake. Again, this is a medication that's approved for use in type 2 diabetes, not type 1 diabetes. The potential benefits are quite long. So there's long-term safety and efficacy data for type 2 diabetes. In type 2 diabetes used as monotherapy, there's no hypoglycemic risk. There's weight loss associated with metformin. There's potential to lower insulin doses. It's cheap, and it's an oral medication compared to the multiple injections that patients with type 1 diabetes have to use. In addition, there's a low side effect profile, the most common of which are nausea and diarrhea. So does it work? Lipman and colleagues looked at metformin being added to insulin therapy for overweight and obese adolescents with type 1 diabetes. In a double-blind, placebo-controlled randomized trial, they looked at adolescents with a mean duration of diabetes of 7 years, and they titrated metformin to 1,000 milligrams twice daily compared to placebo with insulin adjusted as per clinical judgment. Their outcomes demonstrated no significant difference in hemoglobin A1C at the end of 3 months, but however, they did note a reduction in total insulin dose as well as BMI. Nearly a quarter of the patients in the metformin arm were able to reduce their insulin dose by 25%, and a quarter of the patients were able to reduce their BMI standard deviation Z-score by 10%. And in addition, there was no severe hypoglycemia in the metformin group. What's that? Oh, excuse me, there was more severe hypoglycemia in the metformin group. In the removal trial, this was a trial looking at adults with type 1 diabetes, not necessarily overweight, with at least 3 of 10 specified cardiovascular risk factors. Patients were randomized to either receive metformin 1,000 milligrams twice daily or placebo. Now, the investigators here specifically were looking at the potential for metformin to reduce atherosclerosis and cardiovascular risk. In the setting of that, this has been observed in type 2 diabetes. As a surrogate for atherosclerosis, they looked at the mean far wall carotid intima media thickness as a primary outcome. In addition, they looked at, as a secondary outcome, hemoglobin A1c changes. In the primary outcome, there was no significant difference. However, in the secondary outcome, they observed a drop in hemoglobin A1c at 3 months. However, this was not sustained over the 36-month study period. They did note a decrease in insulin dosing over the study period that was sustained, as seen in the right graphic here. But in their conclusion, the investigator said that there was no evidence to support the use of metformin in type 1 diabetes to improve glycemic control. So not a very exciting series of 2 cases looking at metformin. The next class I'll talk about are GLP-1 receptor agonists. Specifically, I'm going to be discussing liraglutide and exenatide. However, there are other agents. Again, these are medications that are FDA approved for type 2 diabetes, and liraglutide has a separate indication for the treatment of obesity. GLP-1 receptor agonists work by decreasing postprandial glucagon, and they also are responsible for decreasing postprandial hyperglycemia. They delay gastric emptying, provide early satiety, and are associated with weight loss. The potential benefits for type 1 diabetes being used as an off-label medication include potential weight loss, a lowering of insulin doses, and a relatively low adverse risk side effect profile, including nausea and vomiting. However, there is a rare serious adverse effect of pancreatitis. Looking at the data for using GLP-1 receptor agonists in type 1 diabetes, I highlighted 3 of the major trials that have been looked at a larger population of patients. You'll see here in the first trial, over 26 weeks, liraglutide was used in 90 patients without a significant difference in A1C drop, however, a significant decrease in weight in the liraglutide arm. Adjunct 1 and 2 are 2 phase 3A trials, industry-sponsored, which looked at liraglutide in type 1 diabetes. Adjunct 1 looked at it for 52 weeks, did not demonstrate a significant difference in A1C lowering capacity, however, did show a significant decrease in weight. And Adjunct 2 actually did show a difference in A1C, and the difference between Adjunct 2 and Adjunct 1 were that there were insulin doses were capped in the titration in the outpatient setting. And there was also, again, decreases in weight. So overall, with GLP-1 receptor agonists, the data is not the most convincing for a decrease in hemoglobin A1C. However, it does suggest there is associated weight loss. The third class, and I think that the one that's the most relevant to our discussion here, are Sglt2 inhibitors, namely canagliflozin, which our patient was taking, empagliflozin, and dapagliflozin. These are all FDA approved for type 2 diabetes. The sodium glucose cotransporter, as the name would suggest, cotransports sodium and glucose in the proximal tubules. They lead to glucose reabsorption in the blood. Inhibitors promote renal excretion of glucose and reduce the blood glucose in an insulin-independent manner. And for this reason are particularly attractive for type 1 diabetes in that it does it in an insulin-independent manner and has the potential to work. I'm going to talk a little bit about the type 2 diabetes trials because this is a relatively new class of medications. Canagliflozin was compared to sitagliptin in a 52-week trial and demonstrated a lowering of A1C, a lowering of A1C, more weight loss, however, a higher rate of genital fungal infections. Empagliflozin, used in combination with insulin and metformin compared to placebo, was studied over 52 weeks and demonstrated a greater A1C reduction, total daily insulin dose reduction, and also weight loss. It's important to note that both canagliflozin and empagliflozin also have cardiovascular outcome trials, which have demonstrated or suggest cardiovascular benefit. Dapagliflozin was compared to glipizide. While it showed similar A1C lowering, it did show superior weight loss and fewer severe hypoglycemia compared to the sulfonylurea class. When used in conjunction with insulin and 2 oral medications, dapagliflozin compared to placebo over 26 weeks showed a decrease in A1C of 0.8%. Again, total daily dose of insulin decreased and weight loss. You'll see that there's a common theme amongst these 3 classes. I'm highlighting insulin dose reduction and also weight loss, 2 of which have been the major obstacles in achieving glycemic control in type 1 diabetes. However, there was a higher rate of hypoglycemia with the dapagliflozin group. And so for these reasons, it's become quite attractive for people with type 1 diabetes to potentially use, in an off-label fashion, Sglt2 inhibitors. The potential benefits are weight loss, lower insulin doses, and a potential cardiovascular benefit. In addition, it's an oral medication, which makes it much more convenient than taking multiple subcutaneous insulin doses. So does it work in type 1 diabetes? So I've highlighted 2 trials. There are many more, which include smaller cohorts of patients. Excuse me. The first of which is empagliflozin, studied in 8 weeks in 40 patients, and it showed a reduction in A1C from 8 to 7.6%, but a pretty significant decrease in insulin dosing and weight. Canagliflozin, tested in 2 different doses compared to placebo, also demonstrated a reduction in A1C and weight loss as well. So while the data supporting the use of off-label medications in improving glycemic control is not overwhelmingly positive, there are potential benefits, and therefore they are being used. So let's go back to euglycemic decay, and specifically our patient in the modern era. This was first reported in 2015 as a collection of case series by collaborators. They described 13 cases of reported euglycemic decay associated with Sglt2 inhibitor use, namely canagliflozin, in 9 individuals, 7 with type 1 diabetes and 2 with type 2 diabetes. What they noted, though, as demonstrated in the CGM plot, which shows their blood glucoses on the day of hospital admission, were a relative stable blood glucose profile. And I've highlighted here where 200 milligrams per deciliter and 300 milligrams per deciliter fall. And you'll note that the vast majority of blood glucoses fall below 200. And in this sort of diagnostic dilemma, which we've kind of talked about in the first case, they postulated and hypothesized potential theories, and came with it a word of warning. And this led ultimately to subsequent publications highlighting the risk of euglycemic decay, and eventually in 2015 led to an FDA drug safety communication where they revised the label of Sglt2 inhibitors for diabetes to include warnings about too much acid in the blood or euglycemic decay and serious urinary tract infections. So what's the prevalence? How common is this? Well, it's a bit hard to determine. In the control trials, the rates of decay are relatively low. Canagliflozin at 0.1% and EMPA at about 0.09%. However, in the FDA adverse reporting system of 7,800 Sglt2 events, there are 192 decay episodes, 71% of which were euglycemic decay, and 39% of which were in patients with type 1 diabetes. So how does this happen? Sglt2 inhibition results in, first, an increased renal an increase in renal clearance of glucose. And therefore, fasting glucose or hepatic gluconeogenesis can actually be maintained with lower insulin doses when Sglt2 channels are inhibited. In addition, lower insulin doses can ultimately lead to ketosis, similar to the mechanisms that I discussed earlier. There's an increase in glucagon, which can further predispose someone to euglycemic decay, especially if they're not taking adequate insulin doses. Lastly, due to the diuretic and natriuretic effect of Sglt2 inhibitors, there's a negative fluid balance, increasing counter-regulatory hormones and ketogenesis. Ultimately, Sglt2 inhibitors can uncouple ketosis from the expected finding of hyperglycemia and decay. Shown against this mechanism that I demonstrated in earlier slides, you'll see that Sglt2 inhibitors, one, can reduce the patient's insulin dose here and in the setting of starvation, with reduced carbohydrate intake, further increase ketone formation. Sglt2 inhibition also increases urinary glucose losses, the combination of which results in a metabolic acidosis and euglycemia, resulting in euglycemic decay. And as I've mentioned here, it presents a bit of a diagnostic dilemma. Hyperglycemia is really one of the hallmark features of DK. I'm going to show here in this slide a chart comparing some of the common lab abnormalities in DK versus euglycemic DK with Sglt2 inhibitors. Glucose levels are typically elevated, but in euglycemic DK, they're normal to slightly elevated. The pH in DK is low, however, it can be significantly lower in euglycemic DK. Bicarbonate levels also are significantly lower. And potassium is a bit of a mixed bag. You can either have low, normal, or increased potassium levels with Sglt2 inhibition, one because of urinary losses, but it can be normal to increased because of relative insulin deficiency. So when you can't simply rely on the labs to make the diagnosis, you ultimately need to do the most simple thing. You need to talk to the patient. So why 45 years later has euglycemic DK become more common? Well, I hope I have demonstrated that there's an increasing use of off-label medication, not of which was occurring 45 years ago when Monroe and colleagues first demonstrated their case series. Not only is there increasing use of off-label medication, there's been the advent of Sglt2 inhibitors, which promote the renal glucose loss. So as clinicians, we simply can't assume that our patients are only taking approved medications. We have to rely on our history-taking skills just as much as the lab results in making the diagnosis. Luckily, the principles in management are actually quite straightforward and very similar to the principles of management of regular old diabetic ketoacidosis. Even in 1973, Monroe and colleagues stated that the principles of treatment are to correct fluid and electrolyte loss and to reestablish carbohydrate metabolism. These are the same core principles as the treatment of diabetic ketoacidosis, namely to address the volume depletion, we have IV fluids, to address carbohydrate metabolism, we have IV insulin, and we have electrolyte repletion to correct the electrolyte loss. Here again is the potential mechanism for Sglt2 inhibitor-induced euglycemic decay. Insulin addresses the reduction in insulin therapy, and IV fluids with dextrose address the urinary glucose losses as well as the volume depletion. So while the treatments are pretty much the same, the actual treatment nuances can vary slightly. Insulin in DK is often dosed in a weight-based fashion. However, typically in euglycemic DK, because of the euglycemia, lower insulin doses are required. Dextrose with IV fluids is commonly used towards the tail end of therapy in DK. However, in euglycemic DK is often needed at the start of treatment in order to promote and allow the continued use of IV insulin. And potassium, while commonly needed in DK, is often needed in much larger quantities in euglycemic DK because of renal losses. So back to our patient. This is this 29-year-old female who presented with euglycemic DKA in the setting of Sglt2 inhibitors, was started on IV insulin on presentation once the diagnosis was made. Dextrose-containing IV fluids were added to maintain glucose levels and maintain normal glycemia. However, due to a persistent metabolic anion gap acidosis, this necessitated an increase in her insulin infusion rate and a concomitant increase in IV fluids. The anion gap approximately closed after 18 hours, and she was eventually transitioned back to a subcutaneous insulin regimen. She was discharged home with discontinuation of canagliflozin. Pictured here is a graph of her labs. In the light blue, you see her glucose levels. In the purple are her bicarbonate levels. And in pink, you see her insulin infusion rates. At time 0, IV insulin was started with an expected drop in both glucose levels. However, this resulted in a need to decrease the insulin infusion. However, and the initiation of dextrose fluids. At these two time points, the patient was noted to have a persistent anion gap acidosis, seen by this sort of stable bicarbonate level, and therefore the insulin infusion rate was increased, and again, the dextrose-containing fluids were also increased to maintain normal blood glucoses. Eventually, at 18 hours, her serum bicarbonate had risen, and the anion gap had closed, and she was transitioned at that point to subcutaneous insulin. So the take-homes for euglycemic DKA treatment is that IV insulin is absolutely required even though the patient is euglycemic in order to suppress ketone formation. Dextrose with IV fluids is often necessary at the initiation of therapy and really often in increasing amounts to permit the continued treatment with IV insulin. And now I'll close with a word of caution. Sotagliflozin is a new investigational drug, which is a combined SGLT1 and 2 inhibitor. Not only does it work on the renal pathway for SGLT2, it also works in the gut where SGLT1 is found. This is being investigated actively as a treatment for type 1 diabetes. Garg and colleagues in the New England Journal in 2017 demonstrated benefits of combined SGLT1 and 2 inhibition, showing a lowering of A1C, a decrease in weight, lowering of blood pressure, and also a lowering in the total daily dose of insulin. However, they did report higher rates of DKA, 3% compared to 0.6%. This medication is currently under FDA review for the use in addition to insulin therapy for type 1 diabetes. And so this is in the horizon, and one of the major reasons that I really wanted to speak about this topic is that not only are off-label medications being increasingly used in the treatment of type 1 diabetes, soon patients will be using FDA-approved, potentially use FDA-approved medications which may increase their risk for euglycemic DKA. I think as clinicians, we both have to have an increased awareness of this potential consequence, and as providers that treat patients living with type 1 diabetes, we also have to educate our patients about the potential risk. So in conclusion, off-label use of type 2 diabetes medications is common in type 1 diabetes, and it's essential to take a detailed medication history to make the diagnosis of euglycemic DKA. Euglycemic DKA must be suspected in any patient who's presenting with signs and symptoms of DKA, metabolic acidosis, or ketonuria, even in the absence of hyperglycemia. And the treatment of euglycemic DKA consists of the same core principles as diabetic ketoacidosis. However, it may be slightly more complex. Insulin is absolutely required for this treatment. With that, I'll close, and thank you, and any questions?
Thanks very much. Is it correct that this syndrome is unusually common in 1 and 2-year-olds compared to other age groups? And if that's correct, where do we go with research in that area?
So the question was, is this common in 1 and 2-year-olds? Was that correct? Actually, it is not as common in 1 and 2-year-olds. Typically, 1 and 2-year-olds will be on monotherapy with just insulin, and they would not have used SGLT1 and 2 inhibitors because oftentimes this isn't being used in an off-label fashion in the pediatric endocrine world. However, if the question is historically if this was more common in young children, also not as commonly reported until more school age when patients can potentially significantly reduce their carbohydrate intake and have sort of the starvation-induced euglycemic DKA. So not so common in very young, which is we're thankful for.
Excellent, David. So one of the things you showed in a lot of the trials of adding adjunctive therapy in type 1 is reduction in insulin dose. What evidence is there that reducing the insulin dosing in a type 1 or even a type 2 has a benefit?
So the major benefit, I think, is more in terms of weight loss and less hypoglycemia, which are not necessarily, I think those are subsequent benefits that as providers that we often see, but not necessarily absolutely documented in the literature to show that with less insulin use, there's an improvement in long-term outcomes. However, the risks of hypoglycemia and also weight gain are pretty well established. I don't know if that.
So David, also great talk. Two questions. One is, I thought I heard you say that glucagon goes up with SGLT2 inhibitors. I didn't know that, and maybe I misunderstood, so could you comment on that? And then we live in a world where ultra-low carb diets are very much in vogue for type 1 diabetes, and so you can see the same sort of scenario unfolding there. And I guess the third thing is it sort of reminds me of diabetes treatment pre-1921 before there was insulin. I mean, this was sort of baseline treatment you're trying to get people to this point?
Yeah, so the first, with glucagon increases in SGLT2 inhibition, I don't believe that the exact mechanism is completely understood about why they observe this, but it is a phenomenon that's been seen and postulated as a potential theory for why patients who may be on SGLT2 inhibitors have an increased risk. The second question about the sort of fad of keto diets and ultra-low carbohydrate diets, certainly, and I think that this is common both in the type 1 diabetes world as well as the type 2 diabetes world as a way to really significantly simplify treatment as well as a way to improve glucose control weight. And so I think that it speaks to the importance that as clinicians we have to understand what's our patient's pattern in terms of how they eat. And what dietary patterns that they're having, because if we know that they are following this sort of very low carbohydrate diet and reducing insulin doses, we have to warn them of the potential for this adverse effect. But I agree, I think it's going to become, and it probably is an increasing phenomenon where it's the sort of the triad of euglycemic DKA as a result of SGLT2 inhibitors, reduction of insulin, and these sort of low carb diets. The third.
But is this happening now in people with the ultra-low carb diets with type 1 diabetes? Are they presenting with euglycemic DKA?
Yeah, so there is ketones present in patients who are following these low carb diets. I don't think that it's well reported in large trials or large cohorts of patients because it's kind of hard to get a group of a lot of people following the keto diets. I don't know offhand the incidence of specifically euglycemic DKA. I know anecdotally I've had a couple of patients who do this, who have had DKA, and the therapy effectively as an outpatient, we tell them to eat more carbs and take more insulin and it resolves. They basically call you up saying, hey, I feel funny, I have nausea and vomiting, or maybe not vomiting, but my blood sugars are fine, so I don't know what's going on. So I think that it is happening. I don't know of a large report that specifically focuses just on euglycemia DK with these keto diets, though. I think there was a third part of the question, but I don't remember.
The third part was just deja vu to prevent
Oh, yes.
more insulin. This is how diabetes was treated, and you hung on the edge of DKA, euglycemic DKA, or hyperglycemic DKA.
Yeah, I think that.
Pancreas reminded me when she was resident, that's what.
That was and I would share that I think that there are some providers that still advocate for that specific approach to treatment for these very low carbohydrate diets. And you're right, they probably are teetering on the edge of, borderline ketone formation. The question is whether, oftentimes these SGLT2 inhibitors are used more when someone's not reaching target, and maybe a patient has other motivations to use them, namely weight loss or reduction in insulin therapy. But those people who are already following this very low carb diets may not be that bothered by their low dose of insulin requirements, and maybe they're already achieving good glycemic control, so the off-label use may be less.
Crystal clear. I really appreciated it. Have there been any genetic variants associated with predisposition that might be used to stratify patients for therapy?
That's a great question. Not that I'm aware of. I think that the challenge up until now has been the relative. I mean, while it's I think in the if you had just listened to this talk, you would think that every person coming into the ER with nausea and vomiting that has type 1 diabetes might have this. But I think in reality, across the nation and across centers, it took the collaboration of, I think, about 6 or 7 centers to come up with those 13 cases in 2015. So I don't think that there's been the ability to gather such a large cohort of patients that have had this diagnosis and then can identify genetic variants which put them at risk. But I don't know of any reports.
Okay, let's thank Dr. Lam.